Okay.
Dr. Gelb in New York had said to a pediatric ophthalmologist to operate it on her. Is there any correlation between this eye disorder and LDS?
Okay, those are good questions. So the first one was about the future and specifically pregnancy and having children. Loeys-Dietz syndrome is what we call a dominant condition, meaning you only have to have one abnormal copy of one of these genes to have Loeys-Dietz syndrome. So any person with Loeys-Dietz syndrome has one copy that's not altered and has one copy that has a change. For each of their children, there'd be a 50-50 chance regarding which copy of the gene they pass on. So one risk would be to pass on Loeys-Dietz syndrome. There are ways of managing that issue. For example, there can be prenatal diagnosis or something even newer called pre-implantation diagnosis for people with Loeys-Dietz syndrome. In prenatal diagnosis, a small amount of fluid from around a developing fetus is taken and analyzed to see if there's a mutation in the cells that are coming off the fetus into the fluid. But some people might decide that they would choose to terminate a pregnancy. Certainly many other people do not make that decision, but that's one option. Pre-implantation diagnosis involves getting the eggs from a mother and sperm from the father, fertilizing outside of the body and allowing the embryos to grow to the 8-cell stage of development. At that point, a single cell is taken from those 8-cell embryos and the genetic test is done. The embryos that don't have the mutation can then be reimplanted into the uterus and will develop perfectly normally. There's no consequence of taking one cell at that very early stage. So that would potentially be a way of someone deciding that they're not going to have a child with Loeys-Dietz syndrome, but avoid the need to terminate an established pregnancy. We do know that there are risks to a woman with Loeys-Dietz syndrome that becomes pregnant. Pregnancy does put a lot of stress on the blood vessels. There's also hormonal changes during pregnancy that influence the strength of the blood vessels. So we do know that there is a risk of blood vessel enlargement, blood vessel tear, blood vessel rupture, and even uterine rupture of the uterus during a pregnancy. That risk, importantly, extends for the first few weeks after the child is delivered. In fact, that appears to be the riskiest time to women with either Marfan syndrome or Loeys-Dietz syndrome, is those 3 to 4 weeks after delivery. So if a woman does decide to become pregnant, she should be followed by someone that's called a high-risk obstetrician that knows how to handle critical events that can occur during pregnancy. Many women have decided that they will have aortic surgery done prior to becoming pregnant, even if their aorta isn't quite at the size where we would typically do surgery. Most people with Loeys-Dietz syndrome can have a type of aortic surgery called a valve sparing procedure. And in that procedure, you get to keep your natural aortic valve so you don't need blood thinners. And that makes pregnancy very easy. If you require blood thinners during pregnancy, it becomes more complicated. We are doing studies right now to try to measure the magnitude of that risk to a pregnant woman. So we need to learn more information before we can give precise answers. But I think the bottom line is that there are many women with Loeys-Dietz syndrome who've had successful, safe pregnancies. But it does require a lot of forethought, a lot of planning, and the risks would vary from person to person based upon their circumstances. So it's important to start thinking about it and talking about it a long time before becoming pregnant. Now, the eye issue, we do know that there are some eye issues, possible eye issues with Loeys-Dietz syndrome. As a group, people with Loeys-Dietz syndrome don't have lens dislocation. As a group, the severity of nearsightedness that we see in Marfan syndrome is not the same in Loeys-Dietz syndrome. It doesn't appear to be as big an issue. There is a low risk of something called retinal detachment in Loeys-Dietz syndrome, where the retina can peel away from the back of the eye. That is a very serious event if it happens, and it's important to get immediate medical care that allows the surgeon to reattach the retina to the back of the eye. But as far as I know, those are the eye issues that we know about. Low risk of nearsightedness, no risk of lens dislocation, mild risk of retinal detachment. Yeah.
A lot of questions, I'm sure everybody here could, but why don't doctors at major teaching hospitals know about LDS and sort of just, this has been my experience, dismiss any talk about it when you bring it up?
It's an excellent question. It's a very frustrating situation. You know, the reality that we have to contend with is that there are thousands of diseases, and every one of those diseases is vying for the attention of medical schools that are teaching medicine to medical students. So you can imagine that cancer and coronary artery disease get a lot of attention, and that issues or diseases that are less frequent get less attention. I'm really encouraged about how quickly the word about Loeys-Dietz syndrome is getting out there. You know, I saw someone this week who said, you know, we went in with this subtle issue with my son, and you know, the first thing that came out of the doctor's mouth is, you need to be thinking about Loeys-Dietz syndrome. I think that it's a major mission of the Loeys-Dietz Syndrome Foundation to get the word out there. You know, last year I gave about 60 talks at medical schools around the country to help get the word out there. But I think the educational materials the Loeys-Dietz Syndrome Foundation are going to help a lot. I think that patient advocacy groups like this group can help a lot by getting the word out in their community. The right answer is that someone with Loeys-Dietz syndrome has to recognize that they are often the expert in the room, and they have to be their own or their child's passionate advocate. If you're getting someone who doesn't either know a lot by virtue of what they're telling you, or that says, I don't know, but I'm going to find out, you need to go find someone else. If you have someone who just dismisses you when you bring up a diagnosis that they don't know, or says, oh, you know, don't worry about what the diagnosis is, my surgery works for everyone, you know, that's a strong signal to you that you have to find someone else to help you. So it's a big obstacle, but I'm actually really encouraged about how many physicians are learning about Loeys-Dietz syndrome.
Just one other thing, if I may, being, as I understand it, the only LDS diagnosed person with a heart transplant, are you doing more research on whether cardiomyopathy may be something we need to look for in LDS patients?
Yeah, so that is certainly on our radar screen. There are, for example, in Marfan syndrome, there's about 1% of people that show heart muscle problems that we can't explain. We're now using the Marfan mice to study the heart muscle itself, you know, what's different about it. Those same studies are planned with the Loeys-Dietz syndrome mice. Our first priority is to try to understand aneurysms, but certainly understanding the impact on heart muscle is something that we will be addressing with the mouse models and with people. Over here, and then I'll come over there. Okay.
I'm glad the question was asked about the frequency of the scans, because my son's had 4 in a row that have been stable, and this spring his neurosurgeon said he wasn't going to recommend that he get the scan again annually. And I said I wanted to come and talk to you because it had always been recommended annually. So I guess I'm more comfortable now with the idea of not doing it annually. But because he's already had the aortic root replacement,
Yes, echo is a no-risk procedure. We do want to pay attention to things like heart muscle and valve function that the echo shows us, but a CT scan or an MRI scan, some types of MRI scans show us less well. So I continue to think that a yearly echo, at a minimum, is the right thing to do.
And just a quick follow-up, so he also mentioned that the CT scans and angiograms are so much more sensitive than the MRI, that if we are looking for subtle changes, an MRI necessarily wouldn't tell you that. So I'm wondering if instead of or every other year MRI, should we be having, throwing in CAT scans in there at some point to detect the smaller changes?
So I think that in the small blood vessels in the head, that MRI does not have as good resolution as CT scans. For many people, what we're telling them is we're going to do MRI scans of the chest, abdomen, and pelvis, but consider doing CT scans every 2 years or every 2.5 years of the head, unless there's something that we're specifically following. Everyone's going to need someone to really seriously sit down and think, what does this person need? What is the frequency that they need? But we always want to weigh risks versus benefits, and we really do have to pay attention to this radiation issue.